It's a pleasure to be here, and my presentation coming back after these two excellent presentations, a lot more basic, because I will talk about interventional radiology, and Catherine Roy can tell you I was always obsessed by interventional radiology, and I have to confess, ultrasound for me was just the third choice when I was doing interventions. Because I was thinking CT, MR, fluoroscopy is resolving my problem in more than 90 cases. That's why, I'm coming to the basic, as I said, plumbing and heating. It really exists. Telling the story, 1940, ultrasound was invented. The first biopsy was done in 72 with ultrasound. That's a long time ago. And today, I think everybody is using especially for liver, kidney, soft tissue ultrasound every day for any biopsy you do. This is something. Is it anything changed between the last 10 years, between the last generation and today? We will see if there is anything. The problem is still always the same thing. When you are doing a biopsy, first of all, you want to see the lesion, and second, you want to see the needle. That's the problem with ultrasound. When the view is not good, you are looking around all the time for the same thing. That's why fusion imaging for us is the key, and we need this. A few years ago, we thought fusion where we were doing. You will have your CT scan, you have your MR, and you have your ultrasound. You are fusing yourself mentally. Means the fusion was done in your head, looking the ultrasound, looking the CT scan, sometimes really scary. Even for the best. Today what's happening, you take the images of the patient or CD or by the packs, you insert it in the ultrasound, and with one button, you do the fusion when your patient is in the field. When it's done, that's what you see. That's the RF ablation. You can see the probes exactly in the middle of the lesion you are ablating, and the MR is confirming you are in the right place. This is something basic. We can do every day. How about the precision of this imaging? We have done a study doing on the table of the CT scan or fusion. Means we have done a CT scan, we have fused it immediately on the same position to see the basic precision of the system. Then we have done our needle insertion, we have done another CT, we have reconstructed the CT exactly in the axis of the ultrasound, and we have calculated the precision of the needle position. In these cases, the precision is about 4.38 millimeters in all cases, extremely precise, and you find this all the time. We found out that precision is less in the z-axis. That's why now, to make it even better, we are always doing another fusion on z-axis, meaning in sagittal view, we do another fusion to make it even better, and the precision is approaching the 2 to 3 millimeters now. It means you can be confident. Plenty of publication in interventional radiology, but majority of them, all majority are about liver. Means that's it. It means, as you can see here, the typical case, you cannot see much on ultrasound, on the nodule. You can see it easily on CT scan. The fusion gives you the possibility to do that easily and safely on these images. Another great indication is when you have multiple nodules. You don't know which one is the necrotic one, and this case was a recurrence after RF ablation. It was very difficult to know which one is which one, and those cases, it's very important to do the fusion, especially even if the sagittal view is not good on the MR, you know exactly which part is the viable part, which part is the necrotic part, and you can even use with the fusion the contrast injection on the MR, confirming exactly which part you should ablate before doing anything you need to do. That's important to see, and this is something which is very helpful for us, the contrast media used in interventional radiology and fusion again. And that's it, the ablation is done with RF electrode positioned in the hyposignal zone with the fusion, so we are sure we are not going to ablate again a necrotic part, which is on ultrasound quite difficult, and this is something very, very useful. If you look at the recent publication in CVR 2015, they have done 295 lesions not seen by ultrasound and ablated them. You can see that the precision is 95.6% of tumor corrected targeted with the fusion, 90% tumor successfully ablated, 544, tumor correctly targeted but incompletely ablated. This is due to the hyperechoic zone. You don't know really what you ablate. And this is excellent. As you can see, really for the liver, this looks excellent. That's a typical example. You see the small nodule. You have to ablate in this case. Here we are. Ultrasound, you don't see much. You agree with me, the resolution is excellent, but the nodule is not seen. With the fusion, you're coming in and you are putting your probes in. Here we are. That's exactly, the fusion is very precise with the vessel around. The ablation is done, and here is the control, perfect ablation. It means for the routine basis, when you use ultrasound, the fusion becomes a key. Today, if I tell my team I remove the fusion, I think it will be a revolution in the department. I cannot come back anymore. Fusion, is it good only for the liver? Is it good when the CT or MR is acquired just prior to ultrasound by the same machine? Should it be performed in the same position? The response is no. Now today, if you have a good fusion, you can make it even if the CT scan is a few weeks old, and even the patient, you put it in the prone and you do the fusion. The fusion can be precise. Even for the chest wall, we are doing majority of our chest wall lesion now with this, and as you can see, the fusion can help us exactly to do it. The patient was positioned in prone, the CT scan was done in a supine position, and you can see finally the lesion. However, there are some limits. You can do the lesion, but still, even if the fusion is good in this bony lesion, we can see exactly where we are, but where is the needle tip? That's become a problem. That's, as you know, in many cases, even if the fusion is good, you cannot find out where is your needle. That's another trouble. You have a solution. You remember, as usual, move the needle. Okay, I can still not see the needle. Okay, move it faster, please. I can still not see the lesion. I think this is not the solution. You know, I think this could not continue like this. We have to do something else. We have to do something else. You know, you're looking like an idiot moving like this. It's not helpful. Needle tracking. Needle tracking is the solution. I can show you now that it was a gadget at the beginning I was thinking, and today we cannot do it differently. You just fix at the basis of your needle the detector, which is very easily fixed. And when you have done it, look at this model. When you don't have it, that's a model, that's a needle, and when you use it, you see the green line and the point showing you exactly that you are in the axis of the needle, and the needle is exactly at this point. In the model, we have proven that if the needle is not torqued, you are always very precise. This was very rewarding, means we know it, and if you are not in the axis of the needle, the line becomes red and the circle becomes large, telling you what you see. You are not in the axis of the needle, you are not there. You are not correct with the fusion. This needle tracking is very useful in the fat. Again, in the fat, the needle is not seen. When you have a very vertical puncture near your ultrasound probe, 2 deep lesions, coaxial biopsy, when you remove the trocar, you cannot see the tip. Repositioning of the needle after ablation in the hyperechoic zone, you don't know where is the tip. Again, out of the plan approach, it means you will see that's very interesting. And finally, non-echoic lesion like bone and lung. In those cases, the typical problem is when you are really parallel to the ultrasound, you don't see the tip of your needle. You need to be more perpendicular to be able to see it. That's why the needle track will really resolve your problem to see exactly where you are. And this is working typically. Look at this. The needle track is showing me where is the needle. You agree? A little bit too large, but the line is green. Here we are. At the moment, I will remove it. I will not see anything again. And here we are. I'm in the lesion. I'm in this chest wall lesion. You can see the tip. But this is without the needle track, nothing. You don't see anything without the needle track. That's important to know, especially with coaxial biopsy needle. I see the needle till here. Where is the tip? Where is the tip of the needle? You turn on the needle track, the tip is here. This is very, very useful. And for the depth is extremely precise. I said the only problem is if you use a too soft needle and you bend it, it could be a problem, but the depth is always precise. That's typically very, very helpful. And that's what we use. Repositioning under ablation, when you have a large lesion and I want to reposition in my hyperechoic ablation zone, I have no view, no clue where my needle is going. That's why the track Needle tracking help for you to reposition on the ultrasound your needle anytime. Fusion and needle tracking. You see, this is an easy case, ultrasound guided. You don't want to stay like this. When you see, you don't need really the needle track. You need needle track when you're out of the field. Means you are moving to tissue you're not biopsying. Typical lesion, again, a fatty lesion. To biopsy this, no clue where is the needle, on the ultrasound. There is no clue. Here we do the biopsy. It was a hibernoma, typical one, and the tip of the needle was precisely showed by our needle track. Lever interventions. That really has changed our view. When you don't want to puncture near the ultrasound probe, that's the key. Here the CT scan is showing me a very nice access, and very short access here. I don't need to be with the needle track and see my needle from the beginning. I can puncture at the distance where the CT scan showed me the puncture. The ultrasound probe is here, and then it means, with the needle track, I can see exactly, even if I'm not in the plan, where is my needle, even puncturing by another approach route. This is really a great, great approach for liver for us. Means we choose more of the approach on the axial CT scan or MR scan to see where is better, not just in the ultrasound window. Here we are, the needle is in position. We are very happy, and we checked it immediately on CT, and as you can see, it was exactly where the machine has showed us. Now moving to the thoracic levels. We have 3 interventional rooms for oncology. Since we have the fusion, we have a 4th room. Means we use one of the office when you see the patient as interventional room 2 because we have the fusion. In those cases, such a lesion of the chest wall, you can do a fusion first to find out where is the lesion because it was difficult to see. Once you have seen it, in this particular case, it was typical the patient moved, but we knew where is the lesion, and because we knew it, we can puncture it directly. Don't watch the CT scan anymore, but I know that's a lesion. Here we are, and you can do your biopsy directly with the needle track, coming in the fat, doing the biopsy, and all of them are positive. Means, again, you are pushing the boundaries in other fields you were not using. Some cases, another case of the lung, do you see anything? Nothing. You agree. The problem is this. That's why we need the fusion. When we do the fusion, in those cases, we see exactly the pathway of the needle. This is not seen because that's a fat. I don't see anything here in this case, just my needle track. And here we are, with and without the needle track. I see the coaxial needle coming here, but when I turn on the needle track, I will see the needle appear. I hope that, well, here we are. Look at this, and how deep I am to do my biopsy with the needle track appearing. Here it is. It appears like this in front of your eyes. Where is the needle tip? Without and with needle track. Means, again, really think about this for the everyday job. When the case is difficult, you have it. It's always very nice. Bone interventions. This is Julien Garneau ideas. He's pushing more and more, making the CT scan empty now for biopsies, which is good for the other interventions. That's a typical humeral fracture, pathological fractures, lung cancer. They said we want a biopsy. The problem is the void zone of ultrasound will never show you anything inside. However, oh, sorry. Sorry, I'm back. Catherine, give me 10 seconds. I'm coming back to where we were. Even the Macintosh is not working. It's scary. Here I am. Here we were. Here it is. You don't have any signal inside, but with the needle track, you can move in and show exactly where your needle is finishing inside and do your biopsy. You approach it 5 millimeters and easily you see I'm inside the lesion, do my biopsy, 1 centimeters, 1.5, and I have my probe. Means now, even for lesion you were not thinking you can use it, you can use ultrasound for doing it. Ultrasound alone is this, fusion is this. Means, again, think about this. Injection of sacroiliac joints done on the ultrasound with fusion with CT scan. This is very easy. Puncture of facets done on the ultrasound. What you couldn't do, today you can do this. In conclusion, sure, everything is not possible. I'm not telling you do everything on ultrasound, but many procedures are possible. And like for Iron Man, he is guided by Jarvis. You have seen the movie, favorite movie of Julien Garneau. we need as interventional radiologists to make it for difficult cases, or Jarvis means the fusion. As you see, there is a big team behind me. I'm not alone. The two guys who worked a lot for this is Julian Enescu and Julien Garnon, who you know very well, I think, for his site. Many people know him like this, more than his typical work site. Thank you very much.